And that's great. And everyone seems to be muted, which we also appreciate tremendously. We will get started in just 2 minutes or so. We'll try to give a few more people a chance to get here. Thank you. And I'd like to welcome you to the first quarterly meeting of 2020 of the resource team for the Community of Practice on Scale Up. Of course, I wish this was under better circumstances, and I really appreciate that all of you and especially our speakers are making time to join us today. We wanted to soldier on to organize this meeting via distance, which we usually have in person, so we could continue advancing on our scale up work. And to that end, we've organized a great opportunity to learn from 3 very experienced people who are directly working on the meeting's technical topic of financing scale up. And as I said, my name is Laura Gueron, and I'm a member of the ExpandNet Secretariat and a technical advisor on Scale Up for the Evidence to Action project, which has been leading this community of practice on systematic approaches to scale up since it was founded in 2013. So before I introduce our speakers, I wanted to thank everyone who was able to participate by providing guidance to this session by completing the survey that we shared. And there was tremendously helpful feedback around the topic of financing scale up, all of which helped shape today's session. So I wanted to just take a moment to summarize a few of the key queries and concerns that the COP respondents shared about the topic. And by the way, the members of the COP represent a wide range of USAID cooperating agencies, universities, donor agencies, and NGOs. So the highlights from the survey: really everybody agreed on the importance of the topic that our COP should address the issue of financing scale up. But within that, of course, there was diversity, and some people leaned more towards the need and desire for good costing information and how to use that for forecasting resource needs for scale up. And then other people were more interested in trying to grasp what works to ensure the sustainment of resources and balancing the relationship between donor funding and achieving country ownership, where governments assume responsibility for financing scale up. And people wanted to hear more about successful strategies for advocacy and other strategies that can be used to mobilize resources for scaling up. And so this is why I'm very pleased that each of our speakers have a great deal of experience in these issues and will be touching on them in varying degrees in their remarks from their experience base. So before I introduce the speakers, I wanted everyone to know that we will be recording today's session because we want to make it available for members of the COP and others who could not join us today. So hopefully that's okay with everybody. And so without further ado, I'm pleased to introduce our 3 speakers. I will introduce each with a little more background on their biography before they speak, but as I said, they have tremendous insight to share on the topic of financing scale up. And as an overview, though, we're fortunate to have with us today Nirmala Ravishankar, who is going to share some of ThinkWell's experience from Kenya. And I've asked her to begin her remarks with a primer on how financing works in public sector health systems in low and middle income countries. Of course, there's no uniformity there, but and it's a very broad topic, but she can help give us a common grounding as we go into the rest of the presentations and discussion. And while Nirmala is speaking and presenting, I hope that you will use the chat box to put in any requests for clarifications while she's on her remarks, which we can handle right after each of the speakers presents. And then at the end of the 3 speakers, we will have some discussion time. And I will kick off that discussion with question for each of the speakers, but I also very much welcome you submitting your bigger questions about financing scale up to the speakers in the chat box as well. And we'll sort those out as the best we can. We may have more than we can answer, in which case I'm afraid we won't be able to do it all, but if there are specific questions earmarked for a specific speaker, they may be able to answer you later. So after Nirmala, we'll be able to hear from Kojo Loko of the Challenge Initiative, which we in the COP had heard about a few years ago when it was then relatively new. And given the tremendous experience that the Challenge Initiative, or TCI, has in the area of mobilizing local government resources in cities and countries globally, we thought it was beneficial to invite them to share their experience now that they've gained a few years of learning. And then following Kojo, our third speaker, we will benefit from hearing from is Clive Mutanga, who has been working at USAID on integrated approaches to health and development. And Clive will share some of his observations of what's working and what are challenges to identifying funding streams in support of multi-sectoral integrated work. So now let me introduce Nirmala, who Dr. Ravishankar is a program director at ThinkWell, where she leads the strategic purchasing for primary healthcare project supported by the Bill and Melinda Gates Foundation. Working across 5 countries, including Burkina Faso, Indonesia, Kenya, the Philippines, and Uganda, ThinkWell is supporting government agencies improve how they allocate resources to healthcare providers for delivering primary health services, with a special focus on family planning and maternal, neonatal, and child health. Drawing insights and learnings from these efforts and sharing them locally, regionally, and globally is a key element of the project. And Nirmala is a health systems specialist who has worked on a range of health financing, health policy, and governance projects in Asia, Africa, and Latin America over 15 years. Before joining ThinkWell in 2018, Nirmala coordinated a multi-partner initiative to link the delivery of primary care services through franchised private providers with government health insurance in Kenya. She managed a technical assistance program at Apton Associates to support country governments to measure and analyze health spending, and led a research initiative to measure development assistance for health at the Institute for Health Metrics and Evaluation. She has her PhD in political science from Harvard. So please remember to chat any questions for clarification during Nirmala's remarks. And now I am pleased to hand over the mic to Nirmala. Thank you for joining us, Nirmala.
Thank you, Laura, for that very kind introduction and for this opportunity to present to you all. I just want to confirm you can see my screen.
Yes, we can.
Great,
Perfectly.
fantastic. And I know we're on a tight schedule, so I'm going to jump right in. I want to start by talking about what we mean by strategic purchasing. After all, purchasing is a word that many of us use in different contexts, and I think it's important to get some of these core definitions right. So when health financing folks talk about purchasing, they're talking about how the allocation of pooled funds to providers of health services on behalf of a population. And so when you think of the health systems framework that WHO puts out or has put out, different versions of it, when we talk about health financing there, we talk in terms of key functions, health financing functions, starting with revenue collection, or where resources for the health system comes from, different sources for funding, how those are pooled, and how agencies like ministries of health or health insurance agencies pool those funds, and then critically how they spend those funds or how they allocate those funds to providers of health services, and that is purchasing. So what does it mean to make that strategic? It means getting ministries of health, health insurance agencies, other such agencies that pool and spend resources to make those decisions be based on information about provider behavior and population health needs to maximize health system goals. It's to move them away from spending money just purely based on inputs, salaries, commodities, operating costs, etc., or just purely based on bills presented by providers of health services, which we all know, those of us living and working in the United States, that doesn't work either. So to get purchasers to think strategically in terms of what goals, health system goals they're maximizing, and linking those decisions to provider behavior and population health needs is at the heart of strategic purchasing, or making purchasing more strategic. Here I want to also stop and say, for us, making purchasing more strategic is not about picking favorite kinds of schemes or saying some particular schemes are strategic and others are not. It's not about saying health insurance is strategic and input-based financing is not, but rather working with key purchasers in every country to think about how they can become more strategic in how they're purchasing. Why focus on strategic purchasing? And my way of answering this question, perhaps because I'm trained as a social scientist, is to take a sort of a historical perspective on how countries have set up their health systems and where they are today. So most low and middle income countries in the post-colonial period set up large networks of public facilities and paid for services through government allocations for salaries, for commodities, etc. Initially, those services were free, but eventually in the course of the 2000s, many of these countries introduced user fees to raise more funds for the public sector. And you start seeing, therefore, that blue bar at the bottom of this little diagram that I've put together to show out-of-pocket spending flowing to public facilities to pay for services. Simultaneously, people have always had to pay for accessing services in private facilities. So there's out-of-pocket spending happening there. And then on the top right corner, you can also see vertical programs coming in to channel subsidies, subsidized commodities, other kinds of support to perhaps both public and private facilities. So this is a very simple, and certainly context will matter and specifics will differ from country to country, but broadly this captures how most low and middle income countries have set up healthcare delivery. And the challenges of this program, this way of going about business, are well known and well documented. First and foremost, weak delivery in the public sector, characterized by absenteeism, by stockouts, concerns regarding quality in both public and private facilities, and then the third one being financial barriers, those out-of-pocket spending, keeping people from accessing services that they need, as well as causing financial hardship. So in recognition of these challenges, countries around the world have been undertaking reforms that now we all refer to as UHC reforms. And World Health Report 2010 summarized sort of what lies at the core of these reforms very nicely when it said, these reforms are first and foremost about bringing more resources to the health sector. They're about reducing these financial barriers and increasing financial protection. And then third, it's about ensuring that available funds are used optimally to improve goals like access and quality. And strategic purchasing, making purchasing more strategic, is key to that third goal. And so countries are doing that kind of reform for strategic purchasing, typically by introducing new purchasing mechanisms and new payment methods. So here I'm talking about introduction of national health insurance schemes or scaling up existing national health insurance schemes. But it's also about, in some country contexts, introducing performance-based financing approaches, or voucher schemes, or user fee reimbursement schemes. So there are many, many manifestations, but at their core, most of these reforms are about introducing new purchasing mechanisms and new methods layered over that base system that I just described in order to send signals to providers to improve on the health system goals that we're trying to achieve. Our project is therefore coming in to ask the question, how are these reforms working in terms of primary healthcare delivery, and then more specifically FP and MNCH within that broader PHC package. All of this text is basically what I just described. So I'm going to say, in order for us to do this, we've adopted what we're calling a systems approach to strategic purchasing, which is just a fancy way of saying that we start by recognizing that all these countries have a complex purchasing ecosystem. There are multiple purchasers, there are multiple schemes, and even if there's one particular purchaser of choice or a particular scheme that seems most relevant for primary healthcare or family planning or MNCH, one needs to understand that broader system and how different schemes interact in order to get even that one preferred scheme of choice right. And so here I've shown an example from Burkina Faso, which I think illustrates this point. An average clinic in Burkina Faso gets a lot of supply side financing, payments for salaries or in-kind contribution in the form of salaries, commodities, some amount of financing for global budgets, and they also get payments through a range of mechanisms that are based on output. So the various voluntary health insurance schemes pay into these facilities. There are user fees collected. There's a new gratuité scheme, which is a user fee reimbursement scheme for MNCH and now family planning, and pay for performance methods. So bottom line, it's a complex landscape. The clinic is getting payments and resource flows, a complex web of resource flows. And given this mix of schemes, there are different signals that the clinic is getting. And the question we're asking is, are these signals aligned? Are some of these signals getting lost perhaps in this noise? And are there ways to make these signals better aligned and improve efficiency? So with that kind of primer and introduction to the concepts, I'm going to just do a quick overview of what this project is. The Strategic Purchasing for Primary Healthcare project is an investment by the Bill and Melinda Gates Foundation implemented by ThinkWell. We started in 2017 and we're scheduled to run till the middle of 2022. We're working in 5 countries. And so if you look at the map at the bottom from left to right, the countries are Burkina Faso, Uganda, Kenya, Philippines, and Indonesia. Across all 5, we're trying to do 2 things. One, work in those countries to leverage strategic purchasing to improve primary healthcare with a focus on FP and MNCH, and to capture learnings from our work in those 5 countries to share both nationally and globally with others. I should say that in all 5 countries, we have colleagues living, working in those countries, typically embedded within ministries of health or national health insurance agencies, or working with those kinds of agencies and subnational governments to improve strategic purchasing. In the 2 Asian countries, Philippines and Indonesia, the bulk of our work is really geared towards the national health insurance programs in those countries that have been clearly identified by the countries as the main vehicle for achieving universal health coverage. Asking the question how those schemes are doing in terms of FP and MNCH. Are they paying for the right kinds of services? Are they contracting the right kinds of providers? Are they sending the right kinds of signals? The 3 African countries have much, much more complex and fragmented purchasing landscapes. And you'll get a sense of that when I, in the next few slides, start talking a lot more about Kenya. And so in these 3 countries, our work is more diverse. In at least 2 of the countries, Burkina Faso and Kenya, we're looking at user fee reimbursement schemes for FP and MNCH and asking how they're working. In at least 2 of the countries, Uganda and Kenya, we're also working on PBF, or results performance-based financing approaches funded by the Global Financing Facility. So it's targeted towards FP and MNCH and improving how those schemes are working. So the next few slides, I'm going to now be pivoting towards talking much more in more depth about our work in Kenya. Just a quick summary of the FP context in Kenya, which I'm sure many people on this call know much better than I do. Kenya as a country has made steady progress in terms of improving MCPR, but that national average and those national trends mask a large amount of disparity between counties And so the graph on the right-hand side, extreme right, it's just showing you a subset of those counties, and you can see the incredible amount of variation across counties when it comes to MCPR. In terms of method mix, the top 3 methods in Kenya are injectables, implants, and pills. And I think it's worth noting that government facilities account for about 60% of users of modern methods. And you can see that in the bottommost bar and the graph on the bottom right-hand corner. The shades of orange show you the public facilities and how much they account for. And public facilities account for over 60% of users of injectables and implants, 2 top methods, as well as IUDs and sterilization. Private providers, so pharmacies and private facilities, are the main source for pills and condoms. So this is the sort of the FP context in Kenya. Now moving to the purchasing landscape in Kenya. Many of you on this call are probably aware Kenya embarked on a process of devolution in 2013, creating 47 counties and transferring several key functions, and health sector was one of the main sectors to be devolved. And so as a result of that, today you have 49 public purchasers of health services in Kenya. What do I mean by that? First, you have the National Ministry of Health that controls tertiary hospitals and directly purchases services from tertiary hospitals. But in terms of, and it also obviously performs a lot of policy functions, regulatory functions, but in terms of other service delivery, it transfers funds to other purchasers. So mainly to county governments and to NHIF. So let's talk about those 2 as purchasers. County governments, the 47 county governments of Kenya, are the main purchasers of primary healthcare services today. They are responsible for the majority of public facilities. So all primary and secondary public sector facilities are controlled by county governments. They pay for salaries, commodities, other operating costs at these public facilities. And then you have NHIF, the National Hospital Insurance Fund, which operates a range of insurance schemes that together account for about 20% of the population. NHIF also manages other government-sponsored schemes for FP&M and MNCH. 2 critical ones being Linda Mama, a free maternity scheme, and I'll be telling you a little bit more about that one in a second, and E2A, a scheme for secondary school children. The funds for these 2 schemes come from the Ministry of Health and the Ministry of Education, respectively, but the implementing agency, the purchasing agency, is NHIF. And NHIF contracts both public and private facilities for all these schemes. So in Kenya, our strategies are to support counties to become more strategic purchasers of primary healthcare services with a focus on Linda Mama. We're also starting to engage in conversations with them to think about how they can leverage purchasing to promote quality standards. We're supporting both at the county level and at the national level the GFF funded program. It's called Transforming Health Systems for Universal Coverage, improving the use of those funds for strategic purchasing, and finally influencing policy dialogue at all levels around convergence of purchasing. So I want to share with you a couple of quick insights from our work on Linda Mama and E2A. So Linda Mama is a scheme, it's pretty simple. Any woman who's pregnant can register with NHIF to access a range of MNCH services, 4 ANC visits, 4 PNC visits, and deliveries, and have NHIF pay any contracted public or private facilities, and the woman doesn't have to pay anything. So the package on paper is very comprehensive. We did a process evaluation with Kemri Wellcome Trust that showed that the benefit package in practice, however, does end up not actually including many critical services, including postpartum family planning and for PNC visits, for example. And this is both due to poor understanding of the package and how the rates are structured. And by that, I mean, if you pay the provider one payment for a PNC visit and no extra payment for postpartum family planning, they have no incentive. They get paid the same amount no matter what happens during that PNC visit. So we were hoping to do a lot of work around this kind of issue with NHIF, but due to a host of reasons, which I can maybe elaborate during the Q&A session, that's been a bit challenging. But in the meantime, we're working with county governments to better understand why public sector facilities are not enrolling as many women and submitting as many claims. To some extent, this is about facility capacity to actually process, submit claims. And it's also about the motivation of hospitals in particular to care about the scheme, given that when NHIF reimburses for these schemes, if that money is not, if hospitals can't retain and spend those funds, and those funds have to be remitted back to the county government, then providers have less of an incentive to participate in the scheme. So across 3 counties, Isiolo, Kilifi, and Makueni, our staff embedded in those counties are working with the county governments to implement, to support them to improve the implementation of the scheme. We're also, we've done some introductory work on NHIF's EduAfia scheme, which targets a key demographic group and an important demographic group from the point of view of FP, and provides a pretty comprehensive cover for secondary school children. But our work, our initial landscaping shows that the scheme is largely used for curative services and is not being currently used for family planning at all, in part because of how the scheme's understood and in part because how the scheme's set up. If a girl needs to get a letter from the school principal, for example, to access services, it makes it unlikely that she will be using said scheme for family planning services. We're also starting to do some work around mapping resource flows for family planning, which I can perhaps talk a little more about later, as I know I'm running out of time. So I want to just end very quickly in 30 seconds by offering some final reflections emerging from this work. First, purchasing is about improving how government agencies pay for different costs of delivering FP services. We need to get governments to be thinking, in addition to bringing more resources to the table, about whom they're purchasing these services from, which providers are they contracting, and how are they paying those providers so as to improve access and quality. Second, strengthening purchasing for FP requires a systems approach. It's not just about one scheme or getting one scheme right, but looking at that full complex array of funding flows and getting better alignment and improving signals to providers. And finally, just a word of, I guess, self-reflection and managing expectations. But strategic purchasing is not a silver bullet, right? In and of itself, it's not a solution to everything. Certainly, we need folks advocating for more resources, for example, for family planning. And we need interventions that look at supply side readiness, supplies capacity of providers to deliver FP services. Strategic purchasing combined with all these other types of interventions is what we are advocating for. Strategic purchasing is a way to think about how, once you get those resources, do you channel it to providers in order to achieve the outcomes that we're looking for. So I will stop there and make a final plug for folks to visit our website, which has a ton of our products already up there, and a lot of what I've described in my presentation is available on our website in briefs and reports and papers, etc. Thanks.
Thank you, Nirmala. It sounds like ThinkWell is playing a critical informational role supporting governments to understand their own financing purchasing systems and where there may be incentives and disincentives so that they can take some steps to address them. We did have one question for you that I hope you can answer quickly. I'm sure there's a longer answer, but the question from our colleague Johannes Lin is about what happens after the project ends in 2022. How will the results be sustained and scaled beyond the project? And for example, if you have a midterm review, it might be worth considering this question explicitly. So do you want to respond to that in a minute?
Yes, thank you. Great question. And I should have perhaps, well, I didn't have time to explain that our project is part of a broader portfolio of investments by the Gates Foundation on strategic purchasing. And so our grant is very much set up as catalytic support to work in certain countries, to work with ministries of health and health insurance agencies to get them to identify gaps, to test out policy reforms, and scale them up. There's a parallel or a sister grant that's looking to build out institutional capacity in Africa in particular for strategic purchasing. And that's part of that longer term strategy. And through our project, we're also very much focused on capturing learnings from the work that we're doing across all 5 countries. And so that's a key, that's this, central to what we're doing, and that we see as a lasting legacy as well from this project.
Great, thank you so much. So now it's my pleasure to introduce Kojo Loko, who, whoops, I just lost my bio. Sorry, Kojo Loko, who has 20 years of experience working in family planning. He has expertise in scaling up programs, especially in reproductive health, building public-private partnerships, and producing results using social marketing approaches. Kojo has managed a large global program, or several large global programs focused on demand generation, supply chain management, service delivery, advocacy with governments, and donor engagement. Prior to his work on the Challenge Initiative, he helped the HC3 project, which is USAID's flagship health and behavior change program under the Center for Communications Programs, which covered several health areas. Kojo's previously served as Senior Technical Advisor for the Global Malaria Networks Project and as Chief of Party and Project Director for the Afford Health Marketing Initiative in Uganda. He has played key roles in leading several social marketing and public-private partnership initiatives in his native Ghana. Most notably, he was Deputy Managing Director at GSMF International, a not-for-profit organization serving the West Africa region, specializing in general project management, social marketing, product marketing, and distribution. Let me hand over the mic to Kojo Loko to tell us about TCI recent learning on financing scale-up. Thank you, Kojo.
Thank you, Laura, and hello, everybody. This morning or afternoon, wherever you are, or evening, I will be sharing with you some learnings that TCI has had over the past 3 years. In my slides, which I hope later can be distributed to the community of practice, basically helps set the background. And so I will jump over 7 slides very quickly. And just to give some context to it, TCI, like I said, is about 3 years old, and we focus on solutions with a specific, in urban locations, with a specific focus on urban poor. And we work in 4 regions, Francophone West Africa in 6 countries there, Nigeria, we're in 11 states in Nigeria, East Africa, Uganda, Tanzania, Kenya, and in India, we're in 31 cities. And we started from 0 3 years ago, scaling up family planning solutions in these locations. And later, I'll just show you some of our results. Can I have the next slide, please? So I just put out the theory of change of TCI, and I just wanted to focus on the fact that if you look at the left part, our focus really is on the local governments. And so the difference with us is we're not working at the national level, we work at the local government level. I'll just leave the theory of change for you to go through when you get the chance. Can I get the next slide, please? Okay, so I'd like to, before I actually go on to talk about the guiding principles that we work with. We do have also 4 interlocking tenets that basically underline our work. It's scale, impact, cost efficiency, and sustainability. We believe that scaling without impact is empty scale. And then impact at scale without increasing cost efficiencies is not viable. And cost efficient impact at scale that is not sustainable will not produce lasting change. So with those 4 interlocking tenets, these guiding principles essentially guide us to ensure that the scale that we're experiencing is sustainable. So working with the local government, it's a demand-driven approach. Demand-driven in that we do not impose on the cities self-select to join. And then they bring their own resources, financial resources and human resources to the table. We focus very strongly on local ownership and systems readiness. Essentially, we do not work anywhere. We make sure that the systems in the location are the type that we can work with that local government to help produce results. But I like to stress on the importance of local ownership. We also help come up with right-fitting best practice interventions, which are connected to what we refer to as the TCI University, where we have codified high-impact approaches that are used in our implementation. We also leverage other platforms in that local government area in our work. And importantly, above all, we use near-time, real-time data for decision-making. And I'll later talk about why that is important, working the local governments and helping them step up their financing. Next slide, please. So these are just some achievements today, just to give you an idea of the scope. We're currently in 94 cities across these regions I talked about. It's important to note that we're reaching about 85 million people. And to date, we have had local government contributions close to 100 million. It is worth noting that over the 3-year period, our challenge fund, which the cities tap into when they put their resources on the table, we have spent only close to about $14 million in the challenge fund, whereas the local contributions are almost to the tune of 100 million. But I must say that 80% of that 100 million is from India. And so India has contributed the largest amount to this local government contribution. Next slide, please. So I have just some reflections here that we have learned or are critical to our programming. The first one I would like to talk about is the engagement of the local governments. I mentioned the importance of local ownership and leadership. Really, they select to join and they come to the table, and we believe in approaching it from a business angle. We have the cities come to the table from a business approach. We 6-month period working with the cities such that if they do not meet up their mutual expectations, we basically walk away. We instill the language of sustainability from the beginning. And we also try to align communication and advocacy efforts with local priorities. So we look at what is going on in the community there and try to align with it. And one critical part of the engagement of the local governments is coaching and strengthening financial capacity of local governments to appreciate the program design. So the political leaders and the technical leaders to carefully understand the program design, budgeting, and timely disbursement. This we have seen has been critical with the engagement of local governments. Next slide, please. Next slide. Uh-oh. Okay, I think we got, all right. So advocacy to help increase the local government support again, is critical. But I like to highlight that we have advocated for FP budget line items in several of these local government areas. And those budget lines are ring-fenced for family planning. Before, family planning was convoluted with several other funds, and that was very difficult in terms of tracking the funds that government is putting into family planning. We have worked also in strengthening where they exist already advocacy core groups. Where they didn't exist, we're helping create them. They've been critical in internal advocacy with political leaders as well as the technical leaders. And then we carefully track the resources and do continuous advocacy. And we have a management tool called RAISE that is used to evaluate the commitments and expenditures to provide action points for advocacy and leadership action. Next slide, please. So having, I like to talk about the importance of the appreciation of the local government in terms of value for money. That is, when they see it, they pay attention really to the program. Our challenge fund, which I did not really explain from the beginning, is that when the local government selects to join TCI, they put their money on the table and they tap into our challenge fund. So we use the challenge fund as a bait, and that's what we did from the beginning. And obviously, almost every local government wanted to come in because obviously they could get some money. But then it attracted them and it motivated them to put their money in there. Through the partnership, they learned what they could get from their unit investment. And then it serves as a motivation to increase the money per annum. One other area that we think has been critical in these local governments to continue to put money in there has been how we have worked to codify high impact approaches through the TCI University. So essentially the local governments are not investing in a Cadillac model of expensive interventions, but highly codified high impact approaches which are streamlined and cost effective, such that the local governments buy into it, adopt it, and they see the results that come out of it. It's also critical that the results are highlighted, both to leadership and the community. We are recently also focusing on community accountability, where the community begins to hold their leaders accountable for what the expectation is in terms of health, and in this particular instance, family planning. Can I get the next slide, please? So apart from the high impact approaches which are being adopted by these local governments, and for which through coaching, technical coaching, they learn how to do it and they go ahead to do it, coordination and management has been critical. We have built capacity, we are building capacity in these local governments to manage and to coordinate their program more effectively. It brings about confidence, and so this aspect of partner coordination helps increase self-reliance at the local government and also helps avoid duplication. So like I said, the local governments lead, we do not implement, they implement, we provide technical coaching. We also provide coaching for them to identify opportunities in their area where they look for other resources, either locally, internationally, but really put them in the management seat to coordinate these efforts. An example is the Somel funds in Nigeria, which local governments have been able to effectively pull out and ring-fence money for family planning. One advantage we realize working at the sub-national level is the fact that the local government is close to the ground and they are able to identify with the challenges on the ground. Therefore, advocacy helps them basically really see what in the environment, and then they act upon it. Next slide, please. Having said that, it hasn't been without challenges. The resources that are being committed by these local governments are not always released and spent. Currently, we are ranking between about 50 to 76% of the committed funds spent. Another challenge we have is the verification of expenditure. That sometimes is a challenge because what government says that they are contributing to the effort, to be able to verify that the money has been used where we're expecting it to be used has also been a challenge. Look, the third one is that the local government frequently prefers to spend their money on specific activities and not others. They like to spend money on procurement of equipment and commodities and not in other activities like social and behavior change, and that has been a challenge. We've also experienced change in political leaders which have affected our financing at the local level, because with advocacy with a group of leaders and then the change, you sometimes have to start afresh. But then there is comfort in the fact that working with the technical leaders in the Ministry of Health, that then helps when new political leaders come for them to continue to advocate. Alignment of financial calendars is also a challenge in terms of the local government's financial calendar, our financial calendar, and other partners that are working with them. And also we realized that we are flying or working on the decentralized policies around these countries, but sometimes decentralization is more on paper than in reality. And therefore the ability of the local governments to really call the shots from a financial perspective becomes a challenge. I think I'd like to stop here. Shall we just have the next slide, which is my conclusion? I think I'm running out of time now. In conclusion, I'd just like to highlight true partnership with local governments, putting them in the driver's seat. It really gives them something that I haven't seen before in my previous work, where they really feel like they are in charge of this. They have to bring up their resources. They have to manage it. They have to look for more resources to get their programs going. We fit into their ongoing needs. We don't create them. And then we advocate for budgetary line items that are ring-fenced. The use of the challenge fund approach has been an interesting approach, which we believe that is creating results. And then the accountability, holding local governments accountable, has also been an area that we are beginning to see the local governments respond to the community's quest to see more action in the area of health and especially primary health care. I think I'll stop here and hope to take questions during the question and answer period. Thank you.
Good. Thank you, Kojo, very much. We did have one quick question from Martha Perrin of Spring Impact, who was interested to hear more about the indicators that TCI is using to assess increases in local government ownership. Of course, you've already talked about the financial flows and that, but are there any other ones that you could share?
Well, so we actually work on an annual basis. So there's a designed program of work which is budgeted. And in that program of work, the government puts up the resources that they want to use to fund that program of work, and therefore they are earmarked within that budget, which is government's resources. And then part of those resources, part of our challenge fund also goes to fund other parts of that program. And so we are able to track on a quarterly basis which activities are being carried out using government funds and which activities are being funded through our challenge fund. It is worth noting that it is a sliding scale in terms of funding, that our challenge fund over the years goes down whilst the local government's money goes up. We have different formulas in terms of how the local government money comes in the different areas. In Francophone West Africa, for example, the local governments create a separate bank account where they put their money in there, and then also our challenge fund. And that joint fund actually funds that program of work. So the indicators that we look to track the resources essentially is a program of work And we also look at the activities that have been spent. But there's a challenge sometimes in terms of verifying how much has been used by government, where it has been used. But each of those the programs which have those budgets, we have cost parameters that go alongside, such that tracking them on a quarterly basis, we're able to track how much of the money has been spent. I hope that answers the question.
Yeah, I think that was very helpful. Thank you. Okay, let me now turn to Clive Mutanga, who is the Population, Environment, and Development Technical Advisor for USAID for the last 6 years, where he serves in the Office of Population and Reproductive Health as the technical leader in the elevation and advancement of the linkages between population, environment, and development. And here he focuses on the intersections and the integration of family planning and the environment. He coordinates and oversees various activities under this portfolio of population, environment, and development, and supports field level activities by providing USAID missions with technical guidance in the design, implementation, and/or evaluation of these kinds of integrated projects and activities. Prior to joining USAID, he worked with Population Action International as Senior Research Associate, where he conducted research linking population, gender, climate change, and environment, and worked with diverse audiences at national, international, regional events to inform policy and programming. He provided strategic leadership and direction to Population Action International's climate program, where he managed budgets and work plans on research and advocacy collaborations and partnerships. Mr. Mutunga is originally from Kenya, where he studied for undergrad and his master's in economics at the University of Nairobi, and a stint in between in Pretoria in South Africa at the university, where he obtained his master's in environment and natural resource economics. Let me turn the mic over to you, Clive. We're very pleased you can be here. Thank you.
Thank you, Laura, and thanks for that kind and glamorous introduction. I appreciate it, and thanks again to all the members of the community of practice for inviting me to your club. I'm honored to be part of that, and today I have the pleasure to provide a few remarks. The great thing is when you are speaking after great speakers like the two who just spoke before me, is that your work is pretty much done. So I'll take the next 6 to 7 minutes so that I can leave some time for questions and answers from the audience to go through some of my thoughts on this important subject of financing for scale up, and I'll use my experience working in the cross-sectoral space. And just to get started, I'll give an example of an activity that was funded through E2A, which was actually designed with scale up in mind, and talk about what that project was able to achieve, and then go to some of the lessons that I've been able to learn from the bigger perspective. So the activity that I'm talking about is known as the health of the people and environment in the Lake Victoria Basin. It implemented a model of integrated population health and environment community development work in Kenya and Uganda. The goal of the project was to increase access to sexual and reproductive health, voluntary family planning being the key of that, and improving maternal and child health care practices while reducing threats to biodiversity conservation in project communities. It also, like I mentioned, aimed to scale up the PHE model at the local, national, and regional levels through institutionalization of PHE approaches in government development planning. And for those who probably don't know about population health and environment, which is popularly referred as PHE programming, this is a cross-sectoral approach that aims to address the complex connections between humans, their health, and the environment by implementing integrated activities that simultaneously improve access to health services, including voluntary family planning and reproductive health, while also helping communities manage natural resources and conserve critical ecosystems. This is based on the premise that in integrating voluntary family planning and reproductive health with broader development and environment interventions not only builds community self-reliance, but it also enables a more resilient population and environment, particularly where population pressure exacerbates unsustainable natural resource use and food insecurity. So since 2011, the HOPE LVB project has done great in integrating PH interventions through a model household approach that promotes health-seeking behaviors and natural resource management at the household level. Household interventions focus on diverse set of areas, including sustainable agriculture, tree farming, improved wash practices, voluntary family planning, clean energy cook stoves, and many others. Model households serve as role models and teachers to other families in target communities, which essentially supports sustainability and ability to scale up. The model households approach intervention also exemplifies PH integration by tangibly demonstrating and reinforcing the behaviors that help families develop healthy and environmentally sustainable ways. The hope is, and experience has shown, that these integrated interventions have achieved lasting behavioral change impacts on community health and natural resource management. So this activity also benefited from USAID funded external evaluation, which I was fortunate to participate in. And actually one of the evaluation question was, has the HOPE LVB's project's explicit focus on systematic planning for scale up resulted in positive outcomes of institutionalization, sustainability, and expansion of the model? I would share the full external evaluation report for those who might be interested to go into the details of what the evaluators found. But overall, the finding was that PH integration helped deliver family planning and reproductive health services to remote communities and created local support for those services and for natural resource management efforts. And as a result of the increased community support and reproductive health services, the findings showed that there were greater outcomes within the specific sectors. In some cases, increases up to 6-fold in terms of MCH indicators, for instance, and FP indicators, but also natural resource management indicators. So I will have 4 minutes and I will talk about some of the key lessons for cross-sector integration. One key lesson is that supportive policy and program environment is critical, and I won't belabor that because Kojo especially has talked about how that is important. We've seen in some of the activities around the globe that my office has supported that you really need to involve the policymakers at the local level. We've seen in some of the projects, including the HOPE LVB, how getting county level policymakers from the various sectors and bringing them together in a county steering committee was effective in helping facilitate establishment of a PHE budget line in a county government in Kenya and Uganda. Second lesson is that for scale up, cross-sectoral funding and partnerships is critical. We know in our development space that we operate around various flavors of funds, and to be able to really scale up, then you are not only looking at health funding, especially for the cross-sectoral space, you are looking at environmental funding, food security funding, and being able to really bring those partnerships together. Sometimes actually it's not increased funding rather than just collaboration and partnerships that are able to demonstrate the ability of leveraging funds from one sector to the other. I would also want to mention the role of multi-stakeholder consortiums that elevate and bring this flexibility. The work that was implemented in Lake Victoria was funded by USAID Office of Population and Reproductive Health, but there were a couple of foundations, MacArthur Foundation and MacArthur and Packard Foundation, as well as other private foundations. So given that certain flavors of funding can only support certain elements, then that, that arrangement brings more flexibility. Like Kojo mentioned, I think collaboration and partnerships for policy planning and project design and implementation are critical, from the community to the regional, to the national, to the regional. And then, of course, we cannot fail to mention the role of champions, whether they are at a donor organization, whether they are at a ministry, a government ministry, whether they are in another fund. So the role of champions cannot be overstated. Then I would also mention something that we always want to make sure that we can take advantage to ensure potential scale up, being able to institute and implement robust measurement, evaluation, documentation, and sharing. We know, for instance, in a sector like ours, the cross-sectoral integration space, the burden of proof is on cross-sectoral integration. We are the ones who have to show the proof of concept that cross-sectoral integration actually works. And we have to be showing the value add for us to really show to policymakers that you need to move from donor funding to scale a very novel and innovative cross-sector activity. So, and we also know that working in the cross-sector space also involves complexity in monitoring, evaluation, and learning. So, how do we make sure that our activities are doing a very good job in measuring, evaluating, and sharing the lessons in integration? Then lastly, I will talk about the role of the private sector as a potential opportunity for financing scale up. We've seen how in the environment space, for instance, how private sectors have been investing in activities that are bread and butter to them, like ecotourism. Some of our cross-sector activities are in that space. So how do we use some of the existing mechanisms, even within, for example, within aid? We have what we call a Global Development Alliance, which calls for one-to-one private sector leverage. How do we use that to really support scale-up financing? So those are some of the lessons I wanted to share with you today. I'm sure probably there'll be an opportunity to share more, but I'll be happy to provide more resources on this. Thank you so much.
Thank you, Clive. Great. So now I didn't see any specific clarification questions for you, but there have been a series of questions rolling in over the course of the remarks. And so let me share one to Kojo that comes from Leah Goldman of Raising Voices, which Leah's asking, could you, Kojo, speak more about how health workers and communities are equipped to hold governments and leaders accountable? She wonders if there's been any backlash or examples of success that you could share in this regard.
Thank you, Laura, and thanks for that. The accountability part of our work is in its nascent stages. We incorporated in our programming roughly about 6 months ago, and still working on that and to find the best way to go about it. However, some of the ways we've gone about is the program implementation teams that sit at these local government locations, which meet on a monthly basis. It consists of the health workers, a representative from the community, and a representative from the youth. Look at data and then find and work out areas in which they need to take action. And therefore that becomes one mouthpiece. Another mouthpiece has been the advocacy core groups. And they are representatives or they are representatives of the community. It includes people from the clergy, from the media, etc. And we have seen in some cases where they have been extremely bold. An example I can call out is Bauchi in Nigeria, where the advocacy core group worked with the governor's office to cause the release of 100 million naira to family planning, which was promised. And so, I remember very well that they spent a lot of time at the governor's office. They eventually worked through the first lady, that's the governor's wife, and it finally got released. So we haven't really seen any backlash per se, but I think with government workers within the Ministry of Health, if they champion this just by themselves, I think they may be a little bit vulnerable. But then when there is a group that consists of the community as well as the health workers, I think it then makes it more or less a more kind of a group that basically is not as vulnerable as just people within the government system. So no, we haven't seen any backlash. And I am beginning to see, or we are beginning to see some results from that area. I would say that we will continue to sharpen some of the approaches, but we are so sure that regarding sustainability and the local governments continuing to do what it is that they do, the importance of community accountability cannot be left out.
Thank you. So Rita of the Evidence to Action Project is asking you, Nirmala, if you could share a little more about the country learning partners work and what approaches and strategies and who are the country partners? She's asking, is it basically the MOH or are there other key partners? And I imagine that varies by country. But maybe you could address that.
Great. Thanks, Laura. Great question. You know, you're right, there are different kinds of partners and they do vary across the countries. Across all countries, we are certainly working with government institutions, not just MOH, but certainly starting with MOH, but in Kenya, for example, our staff are embedded within county governments and working with the county departments of health. And we also have somebody in Kenya working with the Council of Governors, which is an intergovernmental agency. In Indonesia, Philippines, we have staff working closely with the national health insurance agencies in those two countries. So the government counterparts do vary a little bit, but it does go beyond ministries of health. In all countries except currently Philippines, we also have local learning partners. So typically research and analytics institutions. For example, in Kenya, our learning partner is Kemri Wellcome Trust. In Uganda, we're working with Makerere. It varies from country to country, but broadly speaking, either an academic institution or a research policy outfit. We're collaborating with them where we've subcontracted them, to put it very clearly, to undertake analytics for the project. We're also working, final category of partnerships would be other projects that we're coordinating with through MOUs and such like arrangements. For example, we're working with SPARC, the Strategic Purchasing Africa Resource Center. We're working with Track 20 in Kenya. So we're working with other partners of that kind as well. Thanks.
Great, thank you. A question for Kojo. This is actually my question. Kojo, you were explaining a sort of weaning process where the monies from the Challenge Fund are slowly drawn down as a portion of the whole funding for family planning in cities, counties, and countries, and where governments ramp up their portions that they're funding over time. So can you share what has been the experience to ensure that local governments are institutionalizing interventions and sustaining these budgetary commitments after TCI is ending? What kinds of successes can you point to in terms of ensuring sustainability?
Yeah,
And you have
thanks,
to be
Laura, for
quick,
that.
sorry.
Okay, so let me just go straight to the institutionalization of those high impact approaches. So when the high impact approaches are well understood and are being practiced at the local government area, the funding comes from us, it comes from them as well. However, we have seen that as our money goes down, they continue with these high impact approaches. Examples are in India, the fixed days static services that are conducted as a high impact approach are going on without effort in several of the cities. Also, the state governments have adopted these high impact approaches and are actually using them in other cities outside TCI locations. For example, in Nigeria, there are states that beyond the locations that TCI is operating, the states have adopted these high impact approaches and using them. So there is obviously a challenge that as our challenge fund goes down, will they be able to sustain these high impact approaches to the same level that they were doing when we had our full amount of resources in there? It still remains a challenge. But the good thing is that because they led the implementation, they know how to do the implementation. They know how to do their program design for the year, and they know how to budget it. Really, we believe that this will be sustained, and everything points to the fact that it is being sustained. The challenge is that will the level of funding be at the level that allows these high impact approaches to be done at the same level as when there's joint funding? And we are now getting to that point where we'll be seeing that for a fact, to see that the traction is true traction, or whether the finances becomes a challenge.
Thank you, that was really helpful. I was hoping to give each of the speakers maybe a chance for some final closing thought or question to ponder, or any other parting remarks. So maybe in just 30 seconds to a minute, Clive, if I could point to you for any closing remarks.
Sure, I think one of the things that I would like to say is that I feel cross-sector integration would be a way the community of practice would consider for scale up. The fact is that in cases of cross-sector integration, you are bringing together funding streams from different sectors. So if it's really trying to show how health benefits are not only confined to the health sector, and being able to leverage resources from other sectors to really improve health outcomes. So I think that's something that I would be happy to engage and maybe throw some questions to this community of practice. But I see an opportunity to use a cross-sectoral lens to actually promote scale up. Thank you.
Thank you. Nirmala, any closing thoughts? You can also pass.
Just to share that I was, as Kojo was speaking, it was further underscoring the need to sort of marry work on strategic purchasing with advocacy efforts, right? So when he was talking about earmarking funds for family planning, bringing more resources in the budget for family planning, that's very, very important. And then next comes how governments are actually spending those funds, even if they're putting it towards high impact interventions. How are those signals structured for providers? That's where the strategic purchasing discussions that our project is having can perhaps make the most contribution. So I was just thinking more about that as he was speaking.
Wonderful, thank you. And Kojo.
Thanks. I would say that data at the local level, real-time, near-time data is critical to sustain financing. Putting the data of the results before the political leaders, before the health leaders, inspires them to continue what they have begun. Without data, they cannot connect their resources with results. So I would say that one of the critical factors that we are seeing is real-time, near-time data, and strengthening the HMIS at the local government level to use that as a major data source. Thank you.
Thank you. That's a very poignant note to end on. So let me close by thanking all of our speakers for their preparations and participation during a very complicated time, and for all of you, the members of the COP and others joining us. And of course, to the E2A communications team for shepherding us along. I hope that everybody will continue to take necessary precautions to safeguard your health and your families and your colleagues during these difficult times. So goodbye, everyone, and please stay safe. Thank you for coming.
Thank you.
Bye-bye.